All right, so the last time we started with the liver anomalies or pathologies. Yes, and I'm sure we got to liver cirrhosis. Yes. So a quick recap. We talked about the definition that it's actually a complication of liver disease, which involves loss of liver cells and irreversible scarring of the liver. And I made mention of the fact that um, in Africa, hepatitis B is the most culprit, and then we also have alcoholism. Hepatitis C is part of it. I'm talking about the hepatitis B and C viruses. Then also some conditions like fatty liver disease is also a cause. Yeah, and we said that we have about 4 types of cirrhosis. So we mentioned, or stages. We mentioned the stage 1, which involves early fibrosis of the liver, and then we said that stage 1 and 2 are the compensated cirrhosis, meaning that the liver still maintains its synthetic functions. Yes. So stage 2, we said that when there is portal hypertension, meaning the portal veins are dilated, and early on I gave you the measurement, which means it should be less than 15 mm. Average is 13 to 15. Yes, so that's for the stage 2. When it goes beyond that, beyond 15, then we know there is portal hypertension. So the stage 3 and 4 are the decompensated, because for stage 3, there is advanced liver scarring, and also there is what? Abdominal swelling. That means that there is ascites. So once ascites comes in, the liver is decompensated. Yes, it means its synthetic functions have been brought down. And stage 4 can also be life-threatening, because stage 4 is the end stage. Once you get to stage 4, you are at the end stage liver failure or disease, and that one, it needs transplant. Yes, it needs transplant. So that is what we discussed the other time. Yeah, I I explained I explained the reason why there could be ascites. I made mention of hydrostatic pressure and oncotic pressure. I made drawings on the screen to explain those things, how ascites come about. And I don't know if you don't still remember, then you can kindly go back to the notes and read. Or it wasn't this presentation that I talked about those pressures, because I teach other courses too, so maybe it's not this one. Does anybody recall that I made mention of hydrostatic pressure, oncotic pressure, and used it to explain how ascites come about? Oh, no idea, really. But you were on board. Oh, I'm just asking.
Hello, sir. Hello.
Yeah, uh-huh.
Yes, yes, since you mentioned, but you didn't go deeper to the explanation.
Oh, really? So it
Yeah.
means it wasn't your class, or what?
Yeah.
Okay. But which class did I do that with? Think, okay, all right. I think maybe Emmanuel's class or something. All right, okay, fine. That's fine. I will explain that. So let's see something. Some cycle, visual cycle over here. Now, if let's start from the healthy liver here. Mm, Healthy liver. So there's the healthy liver. Okay. So if your liver is healthy, mm, nothing is wrong with the liver. The liver can undergo what we call metabolic syndrome, and other risk factors. Uh, uh So, so metabolic syndrome deals with any conditions that affect metabolism. It could be high, high enzymatic activity. An enzyme we call HMG-CoA reductase can cause a lot of fat deposit in the liver. I think when you have the chance, you can read about this. HMG-CoA reductase is an enzyme. It's nocturnal enzyme. It's not like it doesn't work during the daytime, but its activity peaks at night around 3 a.m. So even though you may not be eating too much fat, but this enzyme can produce excessive fat for you without you asking for it. It will produce it for you. So there are some people, they are not fat, they are not obese, but the slim, slim person, but the fat level is always high. So we have to put the person on drugs. Yes, to inhibit this enzyme. So let's say not only this enzyme, you have other metabolic factors that are causing fat deposit, excessive fat production. This enzyme is more with cholesterol, you understand, but that one too cause fat deposit when it produces it too long for let's say too much. Yes, so when fat is being deposited, sometimes it's not just metabolic syndrome. Sometimes you eat too much fat, excessive fat intake, especially at night. Uh, you are eating fried chicken with a whole lot, and you are eating it too much, morning, afternoon, evening. It's too much. Not just chicken, pork, and those stuffs. If you eat it too much, you are subjecting your body to what? High production of it, of fat. And when fat is excessive, definitely they will start being deposited in the liver. I don't want to go into the I mean details in it because it may confuse you. Uh-huh. So when it gets deposited on the liver, wherever there is a lot of fat, inflammation set in. Yes, fat will call for inflammatory reactions. So that one will now the liver cells will now start to be inflamed. They will be swelling. Then you start feeling some pain at the right upper quadrant over there. You understand? By so doing, the cells being inflamed and recover, inflamed and recover, inflamed and recover, may may undergo what we call fibrosis. Fibrosis of the liver. Fibrosis means that the liver cells are becoming hard. Let me say it that way. Hard, like they are changing from their normal softness to become a bit firm and hard. Do you understand? That is fibrosis. Okay. Let's pause that one day. Let's come back again to the healthy liver. You have your healthy liver again. When you keep drinking alcohol and alcohol and alcohol, alcoholism, not just maybe one unit of alcohol and then in a week you take 1 unit of alcohol and it destroys your liver. No. Mm. You have to be an alcoholic. When we say alcoholic, someone who takes alcohol, like the first thing in the morning is alcohol. Yes, the first thing in the morning is alcohol because the person has been taking alcohol uh, uh, in a way that when alcohol is depleted in the system, all his energy is gone. So it will have to, I mean, cause something like shaking the body for the person to go and take the alcohol because the alcohol has been the main energy for the body. Alcohol has taken over glucose. Yes. So if you don't have the alcohol, no, you can't stay. That's why people, if they are alcoholic, you cannot just take them out of the alcoholism in a day. If you do that, they will get into a condition we call alcohol withdrawal syndrome. Yes. So if you want to take them off the alcohol, you have to take your time. You don't just deprive them of alcohol one day. I'm not giving you alcohol again. By the time you come back, the person is dead. So So if someone keeps taking alcohol, the alcohol becomes the main source of energy for that person. So once alcohol is not in the system, then the person becomes weak and can even die. So this liver is normal. If you keep taking alcohol, the liver will undergo what we call alcoholic hepatitis because alcohol is also toxic to the liver. So the liver cells, which we call hepatocytes, are going to be what? They are going to be affected with the high levels of alcohol that you are taking. Because I told you from the onset that the portal veins are there and they drain the pancreas, the intestines, and then the spleen. So anything that you take in, it has to go through the portal vein to be sent to the liver for approval to enter the blood. Uh, yes, but of course, so there are some chemicals which will not go to the liver. Yes, but most foods or yes edible foods that you put in, even drugs, yes, they most of them will have to go to the liver. Most of them. Uh-huh. So if they go to the liver, they start irritating the liver cells, and there are some mechanisms which will go on. And if it keeps on like that, the liver cells will start, they will be inflamed. Inflammation means that they will be first they will swell up. They will call upon inflammatory mediators and that will cause pain. There will be some form of fever, heat production, and those stuff. So the right upper quadrant, you start feeling pain. When alcohol causes that, the swelling of the hepatocytes and the pain and those inflammatory reactions, the liver will enlarge because the hepatocytes will start being enlarged. So automatically it will enlarge the liver. So we call that alcoholic hepatitis. Hepatitis simply means inflammation of the liver. If you take alcohol too much, alcoholic hepatitis will ensue because of hepatocyte necrosis. Because if inflammation goes on, most of the liver cells are going to die. Yes. And from alcoholic hepatitis, if you don't stop what you're doing, you will enter into a fibrosis. Have you seen? We have come back to this place, fibrosis. The metabolic syndromes, too much fat, will also send you into fibrosis. Do you understand? Now, we are at the fibrotic stage. At, over there, it's either whatever you are doing, you stop doing it so that the liver can be reversed because over there, it can be reversed. That's why stage 1 cirrhosis, there can be what? Reversal. But when you get to the stage 2, because stage 1 is more with fibrosis. When you get to stage 2, Stage 2, at that time, still, even if the liver cannot be reversed completely, the liver is still compensated. So it means that the liver still maintains its functional, synthetic abilities. It's still functioning, even though some parts may be scarred small, but it's still functioning. So that one too, you are fine. When you get to 3 and 4, that one it cannot be reversed. We just manage you. It cannot be reversed. Yes. So the once you get to the cirrhosis stage, you see that over here, the fibrosis, you can see the size of the white inside. When you come to cirrhosis, it thickens and increases. I'm talking about the those white you are seeing inside. It's like scarifications. So scar tissue replaces healthy tissue in the liver. You understand? And once the liver, which were which was having uh, perfusable tissues, now they are scarred all over. How can they be perfused? So scar tissues are not really functional. So the liver will now reduce its functional activities, especially synthetic activities. And if at that time too, whatever you're doing is still on, maybe it is hepatitis B, hepatitis C, virus, or alcoholism that is causing that has sent you to the cirrhosis. If you don't stop there and you keep doing it, then it will progress to hepatocellular carcinoma. That's cancer stage. Once it gets to the cancer stage, that's all. That one, we know that death is imminent, whatever you do, unless you do liver transplant. Yes, even liver transplant, it's something that is not done in our country, Ghana here. No. Mm. What is hepatic steatosis stage? So at what hepatic steatosis stage does it get before the liver gets scarring tissue? Yes, I think that one has we. I'm sure it's in my notes. Yes, it also has some stages, about 4 stages. Yes, and so you see, most of the time, stage 1 and 2 are the stages that are not they 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 are limited. Actually, if you do something about them, it will reverse. But when you get to stage 3 and 4, then you are likely to enter into the deadly liver cirrhosis. Do you understand? Yes, and we shouldn't also forget that there are some people, there are some people, they will not pass through all these stages. Yes, there are some people, they can move straight from alcoholic hepatitis straight to hepatocellular carcinoma. They will not get cirrhosis. Yes. And there are some people, they will move from the fatty liver disease straight to the HCC, which is the hepatocellular carcinoma. They will not go through the cirrhosis. Yeah, so it's from individual to individual. But this is the traditional stages that you have to know. Yes, most people will go through this. Uh-huh. But in everything, we have changes. That is it. So when it gets to the cancer stage, you see, at the cirrhosis stage, cirrhosis, the liver will shrink. The liver will shrink. Yes, it will shrink. When you measure, you get like 11 cm, 10 cm in an adult. Yes, and you see fluid surrounding you see some pool of fluid outlining the liver. And then when it gets to the hepatocellular carcinoma, at that time, the liver can enlarge again. But some people will not even get to the HCC. Some people will not get to the HCC. Some people will get to here the cirrhosis and then may die over there. Yes. Some people will not get to the hepatocellular carcinoma. Yes, they will die at the cirrhotic stage. Yes, that one, most of them will die at the cirrhotic stage. Yeah. The stage 3 and 4, most of them die there, especially when they have come to the hospital, you have admitted this person, you are draining some of the ascitic fluid, and they will bring a letter that they want to send their ward home because they don't have money. Yes, the person will go home and do herbal. Herbal will kill the person quick because herbal, you are still subjecting the liver into or you are putting stress on the liver. Most herbal drugs, it is the liver that will metabolize it. Yes, and the liver is failing, and you are subjecting it into high pressures. It will fail quickly, and then the person will die. So it's not all people that will move to the hepatocellular carcinoma before they die. Some die at the cirrhotic stage. Yeah. So when uh, when fat is being deposited excessively in the liver, we call that fatty liver disease, and that is what hepatic steatosis. Hepatic steatosis. That is accumulation of fat, excessive fat in the liver. All right, so this is the stages. This is the cycle for liver cirrhosis. Now let's go through um, some signs. You understand with regards to the staging. So the compensated cirrhosis and decompensated cirrhosis. Stage one. Let's check the compensated cirrhosis. Stage 1 and 2. They are the compensated. What are we going to see? So when we say clinical, meaning when you do physical examination, what would you see? Or even you can do your investigations. Investigations means that you are doing some either therapeutic investigations or just blood investigations. Fine, but in terms of compensated or decompensated cirrhosis, blood investigations fine may be needed, but but not that needed unless we want to check. We want to, drain some fluid and check for proteins and those things, and also check the blood if there is infection inside or something. You understand? But most of the time, the history alone and physical examination alone, plus endoscopy, if the person is vomiting blood, yes, can be enough. Unless there is severe abdominal pain, that means that the person has developed what we call SBP, spontaneous bacterial peritonitis. That one we have the primary and secondary. So ascites is not painful, but once you start feeling pain, you touch every part of the abdomen, the person is feeling pain, then there is a condition we call spontaneous bacterial peritonitis. There has been translocation of bacteria from the colon into the fluid which has been collected in the abdomen, in the peritoneal cavity. So when bacteria are translocated from the colon because of the stasis of the bowels, and they are seeping through the bowel wall into the abdominal cavity, which is the peritoneum, they are going to cause infection of that fluid, and that will cause generalized abdominal tenderness and generalized abdominal pain, which we call uh, um, uh, how should I even say it? We call it peritonitis, but that peritonitis is actually generalized. So generalized peritonitis, and what this means is that anywhere you put your probe when you are scanning this person, anywhere from the epigastrum to the hypogastrum, anywhere you put your probe, there will be severe tenderness. Yes, you are going to elicit the tenderness, but the pain the patient will tell you. Yes. So once you put the probe there, which like that, anywhere. When you decide to palpate the same thing, that means that there is what? Peritonitis, which is being generalized, meaning the whole abdomen. And that means there has been translocation, movement of bacteria from the intestine to the ascitic fluid to cause the infection. Do you understand? So we call that condition SBP, because normally ascites is not painful. The moment you start feeling pain, that means there is what? SBP, spontaneous bacterial peritonitis. You understand? So that will give pain. That will cause the pain. But generally, ascites is not painful. Mm. Just that it can compromise your breathing, your respiration, breathing in and out. It can compromise it, because if the fluid is too much in the abdomen, definitely the diaphragm cannot contract, because the fluid has occupied the full abdomen. So it means that your breathing may change, the pattern may change. Either you breathe too quick, because if you don't do that, you cannot compensate. You cannot get enough oxygen for the brain and other tissues in the body. All right. So the stages, if you pick stage 1, no varices. When we say varices means that, you see, the portal vein, we know it enters the liver, right? Okay. The moment the portal vein is blocked because of thrombus, or there is high pressure, that's what we call portal hypertension. When we have portal hypertension, that means that there is a problem with the liver, or maybe obstruction in the portal vein. Do you understand? So the moment there is pressure in there, you see, the blood has to find a way. The blood has to find a way to move, because blood from the intestine, the spleen, the pancreas must go to the liver. Now, there is high pressure in that vein, so obstruction somewhere. So the blood cannot be deposited in the liver. What should happen? It has to have a way. That's why we have anastomosis. We have a lot of anastomosis in the abdomen. Meaning, if blood circulation to part A is blocked, part B is there. Just that maybe it will be long. The pathway will be long, but part B will there, it will pass there. Now, for liver cirrhosis, the liver cells, the liver is shrinking, compressed, portal hypertension increases because portal vein is what? Closed up. Now, there will be backflow of blood from the portal vein. And I don't know if you, yes, I think the regular class, I've taught you the circulation to the stomach and other things. Yes, the left gastric vein, which drains the lesser curvature. Left gastric vein is a vein that drains the lesser curvature of the stomach. Do you understand? The left gastric vein actually has a branch to the esophagus. The left gastric vein has a branch to the esophageal veins. Do you understand? So there will be a backflow of blood, and we know that the most of the veins in the GIT, almost all of them, will drain into the portal vein before the portal vein will take you to the liver. Now, portal vein is blocked. So all of them, when they are draining into the portal vein cannot send it anywhere. So now the portal vein will move the blood backwards. When they come back, then they are coming back to their the main veins. So if they come back, the one from the left gastric vein has a connection to the esophagus. Do you understand? And so there will be a backflow of blood through that esophagus, esophageal veins. Do you understand? And the esophageal veins are not noted to contain that pressures. They are not noted to contain that pressure. You understand? So until the blood from the portal vein or the obstruction in the portal vein is corrected, until it is corrected so that blood can flow, then there will continue to be a backflow of blood from the portal vein through the left gastric vein to the esophageal veins. And since the esophageal veins are so tiny, it will rupture. The pressure will rupture them. So the person will be bleeding in the esophagus and it will be moving down into the stomach, moving down into the stomach. So those with hepatitis B, most of the times they vomit and it is bloody or blood because the esophageal veins are rupturing. They are being ruptured and bleeding because they cannot contain that pressure from the portal vein. Do you understand? So most of the time they have to do surgery. Surgery and then correct that. They pass a shunt. Yes, pass a shunt and then correct it so that blood will not go through the portal vein, but it will bypass it, and then it will release the stress. The pressure. You understand? So varices means that the pressure in the portal vein is too elevated, and so there is backflow of blood through its anastomosis. That is from the portal vein back to the left gastric vein. Then the left gastric vein will take it straight upwards to the esophageal veins, the veins supplying the esophagus. And those esophageal veins cannot contain that pressure because it's not made for that. So it will rupture. When it ruptures, you start bleeding in your esophagus. And once you are bleeding in the esophagus, it will drip down to the stomach. And the stomach will be filled with blood. The stomach, instead of food, it will be filled with blood. So when it gets full, it will, because I'm the chemoreceptor trigger zone in the brain, that one will generate vomiting reflex, and then you vomit. So you vomit and it is bloody. So varices, we also call it esophageal varices. It's bleeding through the esophageal veins. You understand? That is varices. But stage 1, there is no varices because the liver is still functioning. Stage 2, varices may happen because stage 2 liver cirrhosis starts shrinking the liver. You understand? So portal hypertension may come up. Portal pressure will increase. So varices can happen in what? Stage 2. But still, the liver has still maintained its synthetic function, meaning there is no ascites. Do you understand? Meaning there is no ascites. Once ascites comes in, the liver synthetic function is what? Deranged. Is deranged. Now, with stage 3, ascites is almost always present. Yes, stage 3, ascites is almost always present. If you don't see it on physical, or if you don't detect it on physical examination, ultrasound will pick it up for stage 3. Even though they are saying that not everyone will have ascites in stage 3, but stage 3 is decompensated. Don't forget, decompensated, the synthetic function ability of the liver has dropped. So definitely there will be ascites. Varices is a constant thing in stage 3. Varices. Stage 4, varices is still there, even though they are saying it will be there or not, but it will be there. The plus or minus means yes or no, on or off. But for stage 4, almost all cases I've seen, for stage 4, most of them, they vomited the blood in the house. When they come to the hospital, you do endoscopy and you also confirm it. Sometimes too, they'll give you the history that they vomited the blood in the house, but by the time they come to the hospital, you check and or with endoscopy, and you don't see any viruses. Even stage 3, it can happen like that. But what I need you to understand is that once you see decompensated cirrhosis, know that ascites viruses are present in about 80% of cases. Yes, yes. So they are common, very common in the stage 3 and 4. Okay. So death for the compensated cirrhosis, stage 1, death is 1%. It doesn't like it's unlikely to kill. Stage 1. Stage 2 is like 3%. But look at the jump from stage 2 to stage 3, 20% death rate. Stage 4 is what? 57%. So you are likely to die from the decompensated. Do you understand? But when you are decompensated, the liver is just warning you that do something. The medical insult must be tackled. If you don't do that, then it will progress towards stage 3 and 4. All right. I think somebody has asked the question. Let me check. Please, does cirrhosis cause swelling in all parts of the body? I'll talk about it in a jiffy. I want to use the pressures to explain. So, how does ascites form? You see, the swelling is not the swelling is as a result of the liver's synthetic ability, which has been dropped. It has come down drastically. That is why we have ascites, and ascites will cause the swelling. Do you understand? So mostly it doesn't start with all parts of your body. First, let me go through the, the mechanism. The blood vessel is like this. This one, I taught Emmanuel's class. Emmanuel, I taught your class where I was talking about the preeclampsias and uh, the rest. I think I talked about proteinuria when I was explaining preeclampsia. I explained everything to you guys. So if you see this as a blood vessel, inside the blood vessel should be blood, right? So inside we have a lot of hydrostatic pressure in there, and outside we have a lot of oncotic pressure here, the blood vessel. Don't forget that inside too we have oncotic pressure, but and then outside we have hydrostatic pressure. But I don't want to confuse you. Just understand it this way. Inside there is strong hydrostatic pressure, and outside there is also strong oncotic pressure. So what happens is that hydrostatic pressure, so if you follow my arrow, hydrostatic pressure tries to push fluid out of the blood vessel through the walls of the blood vessel. Blood is moving in the blood vessel. Blood contains more than 80% fluid. You understand? So that fluid, hydrostatic pressure wants to push it through the walls, these walls, to the outside. And the outside is called interstitium or interstitial space. Interstitial space. Interstitial space or interstitium. That's where your tissues are. The blood vessel is an artery or vein. So hydrostatic pressure will push fluid through the wall and come to the interstitium. Then, as the fluid is trying to come, oncotic pressure will be standing outside, telling the hydrostatic that no, I wouldn't allow this fluid to come out. I'll also push it back. So that's the function of oncotic pressure. So oncotic pressure will also be pushing the fluid back into the blood vessel. So they balance each other. Hydrostatic will try to push it out. Oncotic pressure will be pushing it back. So it means that you are a normal person. The liver is producing it's having its synthetic ability. Why am I saying that? Because oncotic pressure is a pressure exerted by proteins. Pressure exerted by proteins. and it is the liver that is the main producer of those proteins I'm talking about. And the most important protein here is called albumin. So once the liver is failing to produce albumin, meaning the proteins will come down, protein level will drop. If protein levels drop, oncotic pressure will drop because proteins exert oncotic pressure. But if liver is not able to produce the albumin, which is the main protein, then oncotic pressure will drop completely. Once oncotic pressure drops, hydrostatic pressure will still maintain its weight. And therefore, if hydrostatic pressure is 23 millimeter of mercury, I'm giving an example, and oncotic pressure, instead of it to be 23, it has dropped to, let's say, 12 millimeter of mercury. Once that happens, hydrostatic pressure will stand tall and will start pushing the fluid out because there is no oncotic pressure to push it back. The oncotic pressure is it is less. So as hydrostatic is pushing the fluid out, oncotic pressure cannot push it back. It's like a macho man going to fight with an HIV patient who is cachectic, who has reduced in size, and as the person is walking, can even be swinging left and right. So you cannot, you cannot stand with this person, isn't it? The same thing happens when hydrostatic pressure stands tall like that and oncotic pressure drops because the liver cannot produce albumin due to the fact that the liver is having what? Cirrhosis. Now, as hydrostatic pressure is sipping the fluid out, sipping it out, sipping it out, sipping it out, it will be draining in your abdomen. They will be collected first in your abdomen. So your abdomen will be filled with fluid. You understand? When most proteins, when you lose a lot of fluid into your abdomen and your abdomen swells, they say that the person is cursed. Meanwhile, it is the liver that has failed or that is failing. That's at the decompensated stage. Do you understand? So we have some patterns of the fluid accumulation. If it is the liver, the abdomen will swell first. If the cause is coming from the liver, the abdomen will swell first. If the cause is coming from the kidneys, the face and the foot or the feet will swell first. Mostly the feet will swell first, then the face will come up. Sometimes too, the face will be first before the feet. You wake up one morning and your face is swelling like that. Yes. Sometimes it is gradual, not sudden. It will be swelling small, small, and by the time you realize your face is swelling, your your feet will also swell. When you press, then it indent, it goes inside. When you press, the swelling. That is the kidneys. When and and remember, it's both legs. If it's about your legs, it's both legs, not one. If it is one, then you are not thinking of hypoalbuminemia. You are rather thinking of maybe deep vein thrombosis, cellulitis, or something like that, because it cannot happen to one leg. It's the full body, so it's both legs. Full body that will be affected. So it's both legs. When it is also with the heart, because heart can also cause swelling. So the heart, right heart failure. Right heart failure also present with both legs, the lower limbs. So it starts with the feet swelling. So the feet will be swollen like that. Then it will be moving up, moving up, moving up to your knees. Sometimes to your thighs will be swollen. No, so the kidney too can cause that from the feet to your ankle to your the shin area to your knee to your thighs. Yes. So that is it. For the heart, it doesn't deal with the oncotic pressures. And even though even though hydrostatic pressure is part of the mechanism with the heart, but it doesn't deal with albumin. That's what I need you to understand. It doesn't deal with albumin, like the proteins in particular. Yes. But the kidneys and the liver, it is the mechanism I've just written or drawn on the screen. The liver and the kidney. The kidney does not produce albumin, but the kidney has what we call the Bowman's capsule and the glomerulus. So if the pressures are so high and the blood pressure is so high and it is hitting the Bowman's capsule, it will create some space. You see, the kidneys, they don't allow proteins to pass through the Bowman's capsule. They don't allow protein because proteins are large molecules. So the capsule is made up of something we call podocytes. So the podocytes are forming tight junctions over there, preventing large molecules like proteins to pass through. So you don't have to urinate your proteins. Once you start urinating your proteins, proteins are found in the urine. It means that the podocytes are effacement of podocyte. And that means that they have opened up to allow proteins to pass through. So once protein starts to pass through the kidney, I mean, that capsule, Bowman's capsule, and the glomerulus, that means that you are going to urinate your proteins out. And as the liver is the liver is working well. The liver is producing the proteins, but you are urinating the proteins out. So the body will notice that the proteins are low. Unconscious pressure will drop, and that one will cause the same thing, the same mechanism as I explained. Just that the liver is working, but the kidney is the one sending the proteins out. Do you understand? So that is it. How will you know you are? So that is why you must always do checkup. Most of the time, the first thing you will see is that when you urinate, it will be foamy. It will be foamy. That should tell you something. At first, your urine wasn't like that. Now it is like that. So you have to go and do urine routine examination, urine array. It's not expensive. They will do it and tell you that there is proteins. Even when you do urine dipstick, nurses can even do it. They'll tell you that there is what proteins. Yes. And that every prescriber knows that when that happens, there is a problem in the glomerulus or the Bowman's capsule of the kidney. So we check your blood pressure because high blood pressure is the one that mostly is the culprit. It's not only that, but that is the most culprit. Yes, for proteinuria, urinating your proteins out, proteinuria. So that can also cause swelling. It starts from your lower limbs, then the leg itself, then the knee, the thigh, and now come to your abdomen. Don't forget, since it's coming from the kidney, your face is also part of it. Yes, but the liver doesn't start from the face. The liver starts from the abdomen straight before it will now go to the feet. Liver doesn't really present with facial swelling. So the person who asked that can it cause the general body swelling, it's not like it can't do. It can. You understand? It can. But most of the time, cirrhosis, no, it's the abdomen that will be big and then the lower limbs. But in severe cases, we call it anasaka. That's generalized body swelling, which can happen. I think I taught you guys, Eric, anasaka. So anasaka is generalized body swelling. It can happen, but that is the severest level. Most people will not get to that stage and they will die. You understand? Okay. So that is that mechanism. On ultrasound, we find irregular. How do we see cirrhosis on the scan machine, ultrasound machine? On ultrasound, we find irregular rough liver margins, which are macronodular or micronodular cirrhosis. The veins in the liver connect in open angles. Liver reduces in size due to the pressures because there is obstruction, the intra hepatic portal veins, there are obstructions. So the proximal to it are dilated. That's why we are saying that the liver veins connect in open angles. I'll show you some images. So liver reduces in size drastically in liver cirrhosis. Liver reduces in size, but don't forget, when it tends to liver cancer, the liver enlarges. Yes. That's why I said that some people don't even get into the cancer, then they die at the cirrhotic stage. Yes. So parenchyma echogenicity. So when we say micro and macro nodular nodules like masses will be, you will see multiple masses in the liver. Sometimes it's not big. Sometimes they are micro, tiny ones, diffusely seen in the liver. So parenchyma echogenicity is higher, and the tissue seems to be granular. You understand? Granules are rough kind of rough. They are not smooth. So the echogenicity of the liver is what? High, meaning ultrasound will see it as white because of the scarifications, the scar tissues. In advanced stages of the cirrhosis, liver size dwindles and we find marks of portal hypertension. You understand? Liver size will shrink, the liver will shrink. And there are marks of portal hypertension. And how would you know if there is portal hypertension? Ascites. Once you see ascites, uh, portal vein being dilated, then there should be what? Varices also here. I need to add it. Varices, esophageal varices. I have explained the varices to you. So ascites, portal vein dilatation, esophageal varices, and splenomegaly. Why? Splenomegaly, because I told you that portal vein drains three main organs: the intestines, the pancreas, the spleen. You understand? The spleen. Do you understand? So the GIT in particular, it is portal vein that drains it. Do you get it? Stomach. So now, if the portal vein drains the spleen and the portal vein is blocked, it is blocked. Blood cannot move into the liver, and there is backflow of blood. It is the portal vein that is draining the spleen. There is backflow of the blood from the portal vein. What do you think? The blood will move back to those organs again. That is why we even have the varices that I explained to you earlier. To get to the left gastric vein, move to the esophageal varices and rupture those veins in the esophagus, causing varices. Splenomegaly means that, in this case, means that there is backflow of blood from the portal vein, which will move back into the what? Spleen, and it will engorge in the spleen and enlarge the spleen, dilate the splenic veins, intrasplenic veins, and then cause splenic enlargement. So this is the liver. Have you seen the rough margin of the liver? Rough margin. We have seen nice liver last 2-3 weeks. So if you see this liver, you should know this is cirrhotic liver. Cirrhotic. Why? Because you can see rough margins plus fluid surrounding the liver. You can see the liver echogenicity is what? A bit hyper, meaning scarifications. Check someone's liver. There is the liver. There is the liver. Have you seen fluid, pool of fluid outlining its surfaces? Its surfaces over there. So this liver is what? Shrunken. You can see it clearly. This is shrunken liver. If you measure this liver, you get like maybe 10 cm or 11 or something. And this is an adult. Have you seen fluid ascites? Pool of fluid. Now, if you check this one, check the liver echogenicity. Abnormally seen. And you can see fluid, pool of fluid outlining it. So let's move. When we get to the fatty liver disease 2, yes, we will explain it. Now, hepatic cyst. This is very simple. I think there is a question in the chat. Oh, who is asking me normal size of liver in adult? Please, when I started, didn't I talk about this? It's in the notes. I've sent it to you guys. Everything is inside. So why this question now? I hit on it that much. If kindly tell her who is going to answer. Kindly tell her.
That the size should be less than 14 centimeters.
14 cm. Okay. But we are not done. We said something else. Anyone can help?
14 centimeters, depending on the individual structure of the body or the either male or female.
Okay, so we take it up to what limit, what measurement? That we know that above this measurement, in everybody above this measurement, the liver is enlarged.
It says 14 to 15.5.
Exactly. So that's the limit. The limit is 15.5. Everyone's liver must not exceed 15.5, no matter your height or body habitus. So women mostly will have liver 14 cm or less. Men will have it up to 15.5 cm, but not above the 15.5. But I told you that not to be confused, you can use the 15.5 as your benchmark. That the 15.5, every liver must be 15.5 or below. It shouldn't go beyond the 15.5. You guys have the nose, so please go through the nose. And we have done it also. So it's a common finding, hepatic cyst. They are anechogenic, black round regular objects.
So there's a question. So there's a question in the chat box.
Yes, I'll check. So this is hepatic cyst. Hepatic cyst over here. We are describing it, and we are saying that it's a common finding. Hepatic cyst is very common. You may see it every day. Like not that every day, but common. It's something common that you may be picking it up all the time. But don't go and see gallbladder and you refer gallbladder as hepatic cyst. Gallbladder, please. So you should know the difference. If you think that what you are seeing is confusing you, you must see the cyst at the same time. You must see a gallbladder somewhere. Don't see this. Don't see just something in the liver being anechoic and you go and write hepatic cyst. Meanwhile, maybe it is the gallbladder. Do you understand? And that is one of the reason why the person doesn't have to eat before coming for abdominal scan. You don't have to eat. Yes, because when you eat, mostly the food we eat contains oil, lipids. So the gallbladder will squeeze the bile onto the food. And once that happens, the gallbladder will shrink. So you may not see the gallbladder when the person eats. So it's better you come empty stomach. At that time, the gallbladder has its normal size and you measure. It's not only that. When you eat, you swallow gas. A lot of gas go into the bowels. And a lot of gas in the bowels, especially the pancreas, we may not see it because the transverse colon overlies the pancreas. Bowel is an enemy to ultrasound. Gas is an enemy to ultrasound. So when gas is in the transverse colon and covers the pancreas, it's difficult to see unless you exert intense pressure, steady pressure on the probe before it can displace the bowel gas, and then you can see it. Now, hepatic cyst is a common finding. They are anechogenic, black round regular objects inside the liver parenchyma. Often we can see a conic bright shadow behind them, acoustic amplification. So you can see this. This one, we did it in feces. Acoustic enhancement is also called acoustic amplification. This is cyst, black on ultrasound. Now, posterior to it, we have what? Enhancement. That's amplification. So it has a thin wall. Gallbladder has a thick wall, like a normal thick wall, but a cyst like this cyst, simple cyst. This is simple hepatic cyst. Simple hepatic cyst. Why? Because it is one. It doesn't have solid content inside. You understand? So it is simple. And it's giving acoustic amplification here. Let's move. Let me check the question first, and then so those are the compensating stage. Oh, okay. Even somebody wrote the liver size over there. Isa wrote it nicely. All right, that's fine. How will you know that? But one question again is in the chat box. I'm not seeing it though. One question again. Who asked?
I was asking about the liver images that you were presenting. Like I was asking whether it was decompensating type or something like that.
Okay. So the thing is that decompensated. When we say decompensated on ultrasound, what you are going to see first is ascites. Once you see ascites, you should know that it is at least stage 3. Take note. Once you see ascites, know that the liver is decompensated, meaning the liver has lost its synthetic function, or it has reduced drastically. The function has reduced drastically. You understand? So ascites is the first sign that the person is in decompensated cirrhosis. Yes. Sometimes this person will come. You don't see cirrhosis, but you see hepatocellular carcinoma. It will also present with ascites. The liver will be decompensated. Ascites. Then you take the history. They will tell you, oh, he vomited blood in the house. Then you know that is esophageal varices, decompensated. Because esophageal varices, if you don't ask the patient, sometimes you ask the patient will tell you, no, I haven't vomited. Yes, the patient will tell you, I haven't vomited. It doesn't mean that there is no varices. The doctor will do endoscopy, and endoscopy will now tell that indeed there is what? Esophageal varices. Varices also has stages. I think stage 1, 2, 3 or so. Yes, but that one is not your time. You are a sonographer. Yes.
Yeah. So what of passing blood is stool?
Passing blood in stool? No. Yeah. No. For varices, since it is coming from the upper GI, you wouldn't see the blood in the stool, but the stool will be black, and your stool is going to be black. One thing that will help you to know somebody is bleeding from the upper GIT, upper digestive system. So you call it Malina stools. Malina stools. That is black, tarry stools. That means that you bled at the upper part. That means the stomach, the esophagus. That's where you bled. And then the blood has moved through digestion. Yes, it has come to the duodenum, the jejunum, the ileum, and it has been broken down, metabolized, and those stuff. So the iron, the organism will act on the iron, and you see that it will stain the stools. So the stools will come out black. If you like, go and take a blood tonic. Take blood tonic today, morning, evening, and tomorrow morning go to toilet and see. I'm not saying syrup, just syrup, any syrup. I'm saying blood tonic, not just any syrup. Don't go and take a syrup that's a food supplement which doesn't contain iron. I'm saying blood tonic. Blood tonic, when you take, due to the iron content, the next day you go to toilet, it will be black. Your feces will be black. The same thing applies to varices. When you are bleeding on the upper GI, the stools will now pass through all the stages of digestion. So the iron will be acted upon. and so it will change its color to black. Iron stains feces as black. So we call that Malina stools. That one alone will tell you that this person is bleeding from the upper GI. Those people with peptic ulcer disease, when it becomes severe, they come to the hospital, we ask them, have you noticed the change in color of your feces? Yes. What's the color? Black. Then we know that the person is bleeding from the upper GI. So for the feces, you are not going to see blood, like blood, fresh blood. If you see fresh blood, it is not coming from the varices. Fresh blood may be coming from hemorrhoids or dysentery, meaning some parasites are in the colon that are causing you to bleed. That one, it will come out as fresh blood. You see the blood. But this one, it will be malignant stools, black carriage stools. Okay, so liver abscesses, hepatic abscess, which we call liver abscess, is pyogenic liver. It's also called pyogenic liver abscess because you know when you say pyogenic, it means pus. It produces pus. PUS. Pus is what? When you have a pimple and you see some whitish, yellowish fluid, you pop the pimple, the fluid that comes out is pus. When you have a boil, and you pop it, you see the fluid, yellowish, whitish fluid coming out. That's pus. So when we say hepatic abscess is coming from what? It's actually a lesion that contains pus. You understand? So it's a pus-filled area in the liver. Pyogenic means producing pus. A liver abscess can develop from several different sources, including a blood infection, an abdominal infection, abdominal injury which has become infected. So the infection can be caused by bacteria, protozoa, which can be a parasite. So bacteria can cause abscess. But most of the time, liver abscesses are engineered by some parasites. Some parasites. But bacteria are also known to cause abscesses in the body. Any part of the body, bacteria can cause it. Yes. Parasites are also known to do that. You understand? And we will talk about some of the parasites. But first, you can go. This parasite, I wouldn't talk about it. You can go and read about it. E histolytica, or let me write the full name. Entamoeba histolytica. So go and read about Entamoeba histolytica causing hepatic abscess. Just go and read about that. If you put it in AI, it will tell you everything. Go and read about that. When you read, you will know that it is not every food that you have to eat. Buy food outside, you don't microwave, you buy the food, then you are eating. If your system is not strong enough and there is entamoeba infectious cyst in it, then or larvae or something, then they are going to infect you. They first infect the colon. Yes, they infect the small the intestines. When they proliferate, they become many. They now try and pass through the portal veins and be deposited in the liver. And now mostly at the right part of the liver, and they cause liver abscess. Yes, it kills people. So we don't joke. If you are someone that when you go to toilet, the toilet is mostly mucoid. Mucoid means amamai akro. The toilet mostly has that mucoid. Then please go and do stool examination because you are likely to have entamoeba histolytica. And if they are there for long, they will move to the liver and cause hepatic abscess and can destroy the liver subsequently. All right. So features of liver abscess. Liver abscesses are typically poorly demarcated with a variable appearance ranging from predominantly hypoechoic with some internal echoes to hyperechoic. So you see, let me say this: when you go to toilet, it's better you observe your toilet. If you take your health serious, when go to someone will come to the hospital, you ask, what's the appearance of your toilet? And this person will tell you, it's WC, so I don't check. But you have to always observe your toilet. You have to know. The moment there is changes, you know. You don't go to toilet and you pressing phones. Afterwards you get up and go your way. You don't do that. You have to observe your toilet. If you're unable to observe the tea roll when you use it to clean yourself. Observe it. Check. When it is mucoid, you will see. When it is bloody, you will see. But that person doesn't like in front of him. But you don't do that. It's very important you start checking those things. Can a fetus in the uterus get hepatic abscess? Anything can happen. But you see, for fetuses, they may get hepatic cyst. For abscesses, honestly, I haven't come across any unless we research. But of course, in medicine, everything is possible. You understand? Everything is possible, but it's difficult for a fetus to get abscess with the liver. Like it's difficult. It's difficult because the fetus has to be in the fetus has to get kind of infection before that can happen. And fetuses don't normally get infection unless it's coming from the mother. And even their colon, the normal flora are not that's there because their system is not developed. So I'll not say that it is the flora that found their way into the liver and caused that. You understand? So it's something that may be difficult to have. Yeah. But for cyst, anything can cause cyst. So cyst can occur anywhere to anyone at all. But abscess is not just cyst. Abscess, it contains what? Pus. It's not just cyst. So they are poorly demarcated. Yes. Variable appearance can contain fluid, can contain solid, like with thick wall, ranging from predominantly hypoechoic with some internal echoes, meaning the fluid inside is not clear fluid. Abscess is not clear fluid. That's why I described it to you earlier. To hyperechoic, gas bubbles may be seen, especially if gas-producing bacteria like the botulinums and species are there. There are some bacterial species, we call them botulinums. Botulinum species. Tetani is also one. Tetani is so Clostridium botulinum, Clostridium tetani. So they are, so you can go and read about them. Clostridium, tetani and co. For them, the tetani is the one that causes the tetanus. Yes. So they are gas producing organisms. These bacteria, when they have their way into the liver and they cause abscess, you see that the abscess will have gas bubbles inside. So when you take a scan, you see white stuff inside. That's gas. Okay. Color Doppler will demonstrate absence of central perfusion. So abscess, because of the fact that the cells are dead. The cells are dead. That's why they were able to form that pus or pussy kind of fluid. You understand? So the cells are dead. So when you put Doppler on the cells will not show blood flow because they are dead. But the walls may show flow, the wall, but not all the time. But central perfusion may not be there. Central perfusion because the cells are dead. The cells are dead. So you see hepatic abscess. That's the liver, very nice liver over there, but there is an abscess over here. Have you seen the wall is not nice? It's like zigzag wall. Yeah. So if you see this abscess, you can see the wall. You can see. This one too, you can see this abscess over here. You understand? So when you put Doppler on it, there is no way it will show flow inside because the cells are dead in there. And it is painful. Abscesses are painful. Don't forget it. There's one other abscess. There's another abscess. So have you seen Doppler is on it? But the Doppler didn't show flow inside. So you can see the inside or the inside, there is no flow there. But outside, you can see the flow, strips of flow outside. Hepatic cystic echinococcus. So we call it echinococcus or echinococcosis. It depends on your pronunciation, but the spelling should be the same. Yes, echinococcosis. So if you can't mention echinococcosis, then you say CE. Then we know you are talking, or you can say hydatid cyst. Hydatid what? Disease. Or hydatid cyst of the liver. That's because mostly the echinococcosis, people find it difficult to mention. So with the CE, it's a widely endemic helminthic disease caused by infection with larval stage of the Echinococcus granulosus tapeworm. So Echinococcus granulosus tapeworm. It's a tapeworm. Tapeworm, worms. We don't joke with worms. And here's bad. You give the worm to a child, and the mother will come 1 week time and tell you that the kind of worms that child passed out through the feces. It's something else. But now I haven't been hearing of such, even though they are still there. They are in the villages and co. Yes. It doesn't mean that if you stay in the village, you get them all. Some people are in the cities, but they are having these conditions. The tapeworm, they ate them, they swallowed them. It's not like you see the tapeworm and you're swallowing it. No. The larval stage, the larval stage can be mixed with your food and you wouldn't see. Yes, and you eat the food. If the stomach acid fails to kill it, then it will move to the duodenum, and now it goes in there and starts harming you in the intestines. So when they grow well and ovipose, they lay a lot of eggs and co, then the eggs will now come up with new ones, and they will now move through the portal vein and be deposited into the liver. Yes, then they start forming cysts in the liver. So cysts are usually unilocular and can range anywhere from 1 cm to 15 cm in diameter. 1 to 15 centimeters. They are cysts in the liver. In hepatic cystic echinocosis, cystic growth ranges from 1 to 2 mm to 10 mm per year. So if you are someone that doesn't go to the hospital, like men, you and I, the men, yes, we don't like going to the hospital for checkup. So you can have these tapeworm and they will be growing this cyst 10 mm per year. And by the time you go there, your liver, part of the liver is cystic. But the good thing about this organism is that even though they will cause the cyst, but the cyst also has stages. So the cyst can start growing nicely, and the cyst can get to a stage that it will shrink and harden and destroy that cells of the liver over there. Yes. But it can kill. Don't forget that. So they also tend to affect the right loop more frequently. Yes. It's like the entamoeba. Entamoeba to affect the right loop because of the portal flow, the portal blood flow. It deposits more on the right loop first before left. Right. So note, the cyst can occur anywhere in the body, not just the liver. Anywhere in the body. You should take note, anywhere. So World Health Organization classification of cystic echinococcosis. So the first stage is the CL stage, which we call the cystic lesion stage. And at that stage, simple cysts with no internal architecture will be seen. The regular students take note of these things. Know them, the stages, know them. Yes, because you are going to write exams on them. So the cystic lesion stage, simple cyst with no internal architecture. You just see just one cyst. As we saw earlier, the hepatic cyst. You will see something like that at the cystic lesion stage. But you cannot say it is cystic echinocosis at that stage unless they go and do stool RE and find that organism there. Then you can link it to the cyst in the liver. Even that one, you cannot confirm that. You understand? Then the stage 1, because the stage 0 is the CL stage. Then we come to stage 1, which is the active stage. Active stage means that the cyst will start growing. So uniformly anechoic cyst with fine internal echoes may only be visible after patient repositioning. They have something inside. That's why we call it hydrated sand. So you see the cyst like this. And you see that if the patient is lying supine, you see something like sand area here, over here. So what we use to differentiate hydrated cyst or cystic echinocosis, we differentiate this and the stage 1 and the stage 2, the stage 0 here and the stage 1 is that with the stage 1, you will see the sand here, the hydrated sand, you see it here. So if you let the patient turn, when the patient turns to the other side and you capture, if the patient turns to this side, you see that the sand will come to this place. Because the sand moves. Do you understand? That is how it is. We call it hydrated sand. So if you are writing a report and you want us to believe that it is cystic echinocosis that you are talking about or hydrated disease of the liver, you have to make sure that hydrated sand is mentioned, especially in the stage 1, which is the active stage. The stage 1, hydrated sand is always there, is always visible. Yes, even though not all the stages that you see the hydrated sand, but the stage 1 and 2, mostly the hydrated sand are there, the active stages. So the CE stage 2, the CE means cystic echinocosis. Stage 2, that's also the active stage. So over there, the cyst will have daughter cells or daughter cyst. You understand? The stage 1, it is active stage, meaning growth of the cyst is the cyst is actively growing. You understand? And that's where you see the hydrated sand, that when you ask the patient to turn to the other side, the sand will turn and you confirm that it is what? Hydrated sand. So it means hydrated disease of the liver, which is cystic echinocosis of the liver. Do you understand? With the stage 2, is still active stage. At that one, the hydrated sand may still be present though, but what will help you to differentiate the 1 and the 2 is that the stage 2, there will be daughter cyst. Stage 1, you only saw one cyst plus hydrated sand, but stage 2, you are going to see daughter cyst. You see another cyst here, and that's like that. Daughter cyst will be seen, and there will be some divisions. Stage 3, transitional stage, that is when it is moving from being active to being inactive. So that is the transitional stage of the cyst. And at that time, you see the cyst to be calcified. So the cyst may start dying. That's why you see dead cyst. It may start dying. It is changing from active to inactive. It's like a woman moving from reproductive age to enter into menopause. So that age, around 45 years, is transition stage. Do you understand? So transitional stage is when you are changing, the cyst is changing from being active to what? To inactive. So you see the walls of the cyst to be calcified. Then the echinococosis stage 4, inactive or degenerative stage. So that is when the cyst is now inactive, meaning it will be forced to degenerate. It will start shrinking. Mostly it can rupture. When it ruptures, it will release whatever is inside into the peritoneum. Then the 5th stage is also inactive stage. Act like thick, partially or completely calcified wall. You understand? So it may be a bit irregular at this stage because it has been degenerated. So that wall may be thick. The wall may be thick and calcified. At the stage 4. So the stage 3, we are saying complicated cyst, meaning that you may see some maybe something like solid stuff inside. You may not see sand, something like sand, but you may see more solid stuff inside. The stage 5, the wall may be having some arcs, not well defined. You understand? And the wall are going to be also very thick and calcified, white in appearance. Do you understand? These are the stages of the cystic echinococosis, which forms cystic lesions in the liver. So if you check, there's the cystic lesion stage, which is stage 0. Stage 1, you see cyst like this, even though I don't see the hydrated sand in there, but the sand is in there. When you are holding your probe, you see it. Yes. This image was captured likely from endoscopic ultrasound. Yes, that one, the probe is passed through your mouth, through the esophagus into the stomach, and it gets closer to the liver, and it's able to view everything clear. It's not the normal probe that we use. No, we have endoscopic probe. Okay, so the type 2, the stage 2, you are seeing the daughter cyst, right? Have you seen it? If you see these things in the liver, nobody should tell you that these multiloculated cystic lesions is from cystic echinococosis. The hydrated, this daughter cyst. Nothing should tell you. The divisions, the matrices, you understand? Then here, it has started being, it is a transitional stage. So you see that the cysts are dead and it will start shrinking. Yes. Stage 4, it is inactive. So the walls are becoming hard and it has shrunken almost. Over here, then the walls are too hard and calcified. You understand? And this is inactive cyst. Inactive, completely inactive and degenerated. But that part of the liver is damaged. But you see, the liver is an organ that when part is destroyed, it can, and then the source is taken off. That thing that is causing it is taken off. The liver can reform. That's how the liver is. But if the organisms are still in your system and they are still causing more cysts, then it will get to a time the liver will fail. So that's the cystic lesion stage. Have you seen the hydrated sand? That's it. Let me use an ink. This is the sand. There is the sand here. That's the sand. If you let the patient, so we call it snowflake sign. Anytime you hear the word pathognomonic means it is consistent, it confirms, that is confirmation. So anytime you see the snowflake sign, which is the hydrated sand sign, snowflake sign, it is pathognomonic for what? EC or cystic echinococosis or hydrated disease of the liver. When you see the double line sign also, this double line sign is also pathognomonic. You see a daughter cyst here, you see another cyst plus the line, the thick line dividing them. That's also a pathognomonic for what? For CE. Do you understand? Okay, because a normal cyst of the liver will not have these signs. So you can see this, transitional stage. You can see this is what the stage 2, which is having a lot of daughter cells, manya stuff like that. Okay, so fatty liver disease. Somebody is asking symptoms for, it's a tapeworm. It's a tapeworm. So once it's a tapeworm, definitely you are going to have low abdominal pain, but it may not be that severe. So sometimes you may not even think of it that, oh, let me go to the hospital. It may not be severe. The low abdominal pain will be there until it shifts to both right upper quadrant and still low abdominal pain. Sorry, not lower abdominal pain. I mean abdominal pain. And then it will also, with time, the pain, you start feeling the pain also at the right upper quadrant, which is the right hypochondriac region and even the epigastric region. Yes. So those little pains, you shouldn't also forget that hepatitis B, C can also cause it. So that's why anytime you sense something abnormal in your system, go to the hospital for checkup. Because these things, until you do stool array, it will be difficult to pick it up. Yes, you do stool array, you do full blood count, the eosinophils count will increase, and then we know there are some parasites in your system or maybe allergies. Even though allergies are more with basophils, but eosinophils are also affected. So there are no particular signs or symptoms, but then if you notice that you have some dull abdominal pain, sometimes at the right upper quadrant, those stuffs, you can go to the hospital. But these parasites can also cause you to see blood in your stools. So you shouldn't forget that also. That's why I told you guys that you should always be checking your stools. You don't go to toilet and forget about it. That it is WC. So everybody uses WC. But if you're observant, you know the color of your feces. Yes, it doesn't matter of just throwing a torchlight on the feces. You will see it. Yeah, and even when you're cleaning yourself, you will see the color. All right. So fatty liver disease or hepatic steatosis is a condition where excess fat builds up in the liver. I gave a review on this earlier. Often there are no or few symptoms. You understand? Occasionally, there may be tiredness or pain in the right upper side of the abdomen. That's occasional. There will be, or there may be, not even there will be, maybe. So it means that you may have pain or not. It's symptomatic. Complications may include cirrhosis. So once you have fatty liver disease, there will be what? Inflammatory reactions, which can lead to what? Cirrhosis, which can also progress to liver cancer. And you know that with cirrhosis alone, oesophageal can happen. Liver cancer can cause oesophageal also, and death will continue. So there are two types not associated with alcohol. So that's why when the person comes and you see cirrhosis, you don't be quick and write just cirrhosis. Or when you see fatty liver disease, then the person is quick. Type 1 fatty liver disease, please. Take history. Please, have you taken alcohol before? That's the question you should ask. You don't ask, please, do you drink alcohol? Please, have you in your life taken some alcohol before? Then the person will tell you, yes. So when was the last time you took some? Oh, last week. Sometimes the moment the person says last week, the relative will say, oh boy, he's lying. Even yesterday, he took some. That should tell you that this person is what? An alcoholic. Sometimes too, the relative should be outside, and then you take your history from the patient. If the patient wants the relative to be outside or stand there, you have to ask the patient, but not in the presence of the relative. And you're asking the patient that, do you want the relative to be inside or not, please? Sometimes it's the wife. And the wife, definitely, he cannot send her away. So the wife can sometimes give very important information that the man can hide. Yes. So it's also important to sometimes take history from relatives. Yes. Okay, so you take history. If the person is taking alcohol, you know that this alcohol, this fatty liver disease may be associated. You understand with the alcohol intake. So the two types not associated with they are not associated with alcohol is the NAFLD and the NASH. So non-alcoholic fatty liver disease and the non-alcoholic steatohepatitis. So non-alcoholic fatty liver disease is called metabolic associated fatty liver disease because now they have changed that NAFLD. Now the term is metabolic associated fatty liver disease. Yes, that's the new term. It's excessive fat buildup in the liver without another clear cause, such as alcohol use. Do you understand? So excessive fat buildup in the liver without any clear cause like alcohol. Do you understand? And that is why I gave you the HMG-CoA reductase. Now go and read about it. HMG-CoA reductase is an enzyme that can produce a lot of cholesterol for your system. And excessive cholesterol will be deposited as fat on the liver and in the liver. So when that happens, it is non-alcoholic. It's not related to alcohol. Alcohol, when we keep taking alcohol, it also causes excessive production of fat, and there is fatty fat buildup deposited in the liver. Yes. Now NASH, same definition as above. NASH has same definition as above, but that one there is what? Inflammation. Take note too. With the MAFLD, which is the metabolic associated fatty liver disease, that one, it only deals with fat deposition in and on the liver without any inflammation. Take note. But the NASH, which is the non-alcoholic steatohepatitis, the NASH deals with fat deposition in and on the liver, but with what? Inflammatory reactions. That's inflammation. So that is why that name is steatohepatitis. The hepatitis has come in because hepatitis means inflammation. So anytime you hear the word hepatitis, it's inflammation of what? The liver. Hepa is liver. So NASH, non-alcoholic steatohepatitis. Same definition as this, but the moment you hear hepatitis, know that you have to add inflammation to it, to the definition. So the metabolic dysfunction associated fatty liver disease is less dangerous than NASH because that one there is no inflammation, it's just fat buildup. So it's not that dangerous. But the NASH is dangerous. But if you don't treat, both can subsequently progress to liver cirrhosis and hepatocellular carcinoma and death. So alcoholic, now let's talk about those associated with alcoholism. Today I may borrow your time for, it's now 7:17 because I want to complete the pathologies of the liver and then we end. We'll finish soon. So alcoholic steatohepatitis is a type of alcoholic fatty liver disease. You understand? It happens when a buildup of excess fat in the liver is accompanied by liver inflammation. And don't forget, that is when the person takes too much alcohol. If you don't take too much alcohol, alcoholic steatohepatitis cannot occur. But NASH can occur, and the MAFLD can also occur. But if you don't take if you take alcohol, that condition that will occur is the alcohol-associated one, which is the alcoholic steatohepatitis. The steato here means that fat deposit, steato. Hepatitis is inflammation of the liver. And alcoholic means it is related to what? Alcohol intake. Yes. So those people with this condition, you go to toilet, you flush the WC, then the feces will be pale and it will be floating. You flush 10 times, it will be floating on the on the surface of the water. That feces will not go down because it is less dense than water. So it will float because of the fatty deposit in feces. And the reason is that bile, because of the fact that the liver is inflamed, it can close up the common bile duct, or it will not be able to produce bile. And so bile may not be secreted onto the fatty foods that you took. It means that if bile is not secreted onto the food cannot be what? Emulsified. And if that food cannot be emulsified, then it cannot be digested. That is simple. So the food that you took in, the liver churned the food, but it couldn't digest. So it will pass through the small intestine, come to the colon, and it comes out as feces. Fat has been deposited on that stool, and it will be less dense than water, so it will be floating on the surface of the water. You flush 20 times, it will still be floating there, and that is steatosis. So when it is causing inflammation of the liver, we call it steatohepatitis. When it's associated with alcoholism, then alcoholic steatohepatitis. It can resolve when alcohol intake is avoided for a few weeks. You understand? Once you stop the alcoholism, definitely the liver will have time to recover. That's it. It is generally a benign condition, but in minority of patients, it can progress to liver failure. That means in few people, when you keep on taking the alcohol, then it can progress to liver cirrhosis. It is diagnosed when there is hepatitis with increased fat deposit in an alcoholic. That's the criteria. Hepatitis on ultrasound means the liver is enlarged. You press your probe there is pain, hepatitis. Then you see fat deposit also on the liver. You see, you take your history, the person tells you, yes, I take alcohol. Oh, even yesterday I took some when I woke up. Alcoholic. So these criteria confirms what? Alcoholic steatohepatitis. So on ultrasound, you see them as bright hepatic echoes. Bright hepatic echoes increase hepatorenal echogenicity, and vascular blurring of portal or hepatic vein have been classified as what? Unique sonographic features of fatty liver disease. So you see, increased hepatorenal echogenicity. So when you compare the liver and the kidneys, you'll see that there has been increase in echogenicity. Bright hepatic echoes, meaning that the liver, part of the liver will show what? Hyper, because of a deposit of fat. Vascular blurring, you see, the portal veins, hepatic veins, diaphragm may be blurred because fat has been what? Deposited on them. So you may not see them clear as a normal liver. So the gradings, we have grade 0 up to grade 3, so 4 gradings. So when the grade 0, when the echo texture of the liver is normal, it's normal in an alcoholic. The person is taking alcohol, but the echogenicity of the liver is normal. The liver is not enlarged. The mild, that is score 1, when there is a slight and diffuse increase of liver echogenicity with normal visualization of the diaphragm and of the portal vein wall. So you see that the liver has changed its echogenicity small, but it still looks normal, but it has changed slightly. And you see that the diaphragm and the portal veins, how you see it in a normal person is what? Reduced. So it is blaring, but it's not bled, it's blaring. It's on the process. The moderate, there is moderate increase of liver echogenicity with slightly impaired appearance of the portal vein wall and the diaphragm. So the score 1, when you come to score 2, that same thing will increase. Do you understand? So the echogenicity will now increase from being mild to what? Moderate. You see that it has changed drastically. So you see that it has changed. The echogenicity of the liver is not normal anymore. You understand? And you now see the portal vein and the diaphragm, you see them bled. Not completely bled, but you see them more bled than the stage 1. With the severe one, which is the stage 3, there is marked increase in liver echogenicity. So you see that the echogenicity of the liver, it has changed drastically, different altogether. And then there is no visualization of portal vein, diaphragm, and even posterior part of the right loop. So the posterior part of the right loop, portal vein, diaphragm may be masked, like you may not see them because fat have covered all. So plus or minus focal hyposteatosis, plus or minus. So there will be some deposit of some black or dark fatty component also, which I think I have some in my images. So if you check this one, the number 1 is parenchyma hyperechogenicity. So if you check over here, have you seen it? So have you seen the hepatorenal increment in the echogenicity. Have you seen the liver? There's the liver. You are seeing it as white. Check the kidney. Now the kidney is rather appearing black, but it shouldn't be like this. It is because the liver is white. That's why you are seeing the kidneys to be like that. The 2 is intensified attenuation. That's the 2. Have you seen that the beam will come all the way to this place, but when it gets here, now the posterior part of the right loop is not seen. All the way, the beam have been absorbed by the fat. They are attenuated. We did it in physics. Poorly visible vessels. That's the number 3. Have you seen one of the portal vein? You don't even see it because fat deposits have covered it. Then hyposteatosis. Have you seen the fat, the black kind of the fat itself is not black, but on ultrasound, the fat can be seen like this also. It can be seen like this. We call it focal hyposteatosis. Hyposteatosis, meaning the fat is forming something like nodule, something like a focal mass, which can be picked up like this. Like this. We call it focal hyposteatosis. So these are the various stages of fatty liver. So have you seen this? Have you seen this? The diaphragm is bled. You don't even see the diaphragm well. Yes, all this place white. Check here, attenuation. Do you see the portal veins and the hepatic veins well? No. Check here. The portal veins and the hepatic veins are in there, but they are not clear at all. Check the echogenicity of the liver. Abnormally seen. It is abnormal. This is not a normal liver, highly abnormal, because we have seen normal livers earlier. Check the diaphragm. It is bled. You cannot see the diaphragm well. It is bled. It's supposed to be white, not normal white. It's bled. Have you seen the normal liver here? Very nice. Very nice liver. Have you seen the portal veins and the hepatic veins inside? Very nice. Check this one. Can you compare this echogenicity of the liver to this one? No, never. Can you compare this scarred liver to this one? No. Check the diaphragm. Very white, nicely bordered. Check here. Do you even see any clear diaphragm here? No. So that should tell you it is what fatty liver. Here you are even seeing the ascites. So hepatic malignancies, I think they are just 2 or so, and then we are done. So
there's a question.
Yes, I'll check. Let me finish with them first. So if you check the cirrhosis, we said that they can progress to form cancers, and that cancer is the primary cancer, which we call hepatocellular carcinoma. Hepatocellular carcinoma is the most common type of primary liver cancer. The most common type. When we say primary means that the cancer started from that same organ. It didn't start anywhere. But when we say secondary cancer, it means that when, let's say, the liver, the cancer starts from the liver, which we call the primary cancer, it can metastasize to the head of the pancreas. And that will be a secondary cancer. Do you understand? Because it has moved from the primary to the next organ, which is secondary. Do you get it? So that is what we call metastasis. Metastasis are our secondary cancers, spreading of cancers from one organ to the other. But if it started from the liver, you cannot say secondary cancer in the liver because it started from the liver. So it is primary cancer. But if it started in the pancreas and now it has spread to the liver, then we say that there is what metastasis of the liver, meaning it has spread from the pancreas to the liver. It is secondary cancer. But so in the pancreas, which it started from, it will be what? Primary. But where it has spread to will be secondary. I hope you understand. So you'll be meeting these things, especially those of you who are doing your first degree. So HCC occurs most often in people with chronic liver diseases, such as cirrhosis caused by Hep B, Hep C infection, alcoholism, Wilson's disease, or hemochromatosis. So we have talked about the fact that hepatitis B can cause cirrhosis, and I gave you the cycle that cirrhosis can progress to liver cancer, or you can die from cirrhosis without getting to cancer.
hepatitis C, the same thing, alcoholism, the same thing. We have talked about it. However, Wilson's disease is accumulation of excess copper, accumulation of copper. Copper in the liver, being when copper is excessive, because we have copper in our system, but if it becomes excessive and deposit in the liver, then it is going to cause continuous inflammatory reactions, which can also cause scarification of the liver to cause cirrhosis, and that will lead to hepatocellular carcinoma. Then we have hemochromatosis, accumulation of excess iron in the liver, and that one too, when iron is in excess, definitely it will generate inflammatory mediators, and there will be inflammatory reactions, and that one will cause cells to die and try to recover, forming scars, and that scar will now continue to form the cirrhosis. Aflatoxins, we shouldn't joke with aflatoxins. Aflatoxins are caused by an organism called Aspergillus flavus. Aspergillus flavus, yes, is an organism. And this organism, the food we eat, sometimes they are in it. When you cut cassava and you put the cassava there, you cut it, you put it there just like that, that later you are going to use, it can have aspergillus on it. You see, microorganisms are ubiquitous. Ubiquitous means that they are everywhere. Don't cut onion and put it there. If you like, put it in a fridge. If you put it there, it can attract some bacteria deposit on it. If you cut cassava, you put it there, it can attract bacteria and even some other organism deposit on it. Do you understand? Aflatoxins are poison generated from this organism, which we call Aspergillus flavus. We have other Aspergillus species. Yes, so the toxins they produce when they come into your system, or you put the food there and then they produce some toxins on it and you eat, it can cause acute liver failure. Yes, Aspergillus species can produce some toxins in your system that can damage their hepatotoxic, meaning they kill the liver cells. So we call it aflatoxins. You can go and read more about that. Yes, you can go and read more about that. It's not everything that I can explain from head to toe. So sometimes you have to write them down, go and read more on it and understand. Okay, so HCC in the hospital, you not hear anybody saying hepatocellular carcinoma. It's too long. HCC, then you are good to go. So you have to have it in mind that HCC is that primary cancer we are talking about here. So high propensity for vascular invasion. Yes, it is highly metastasizing, meaning it can spread easily. So it can spread and affect the portal veins, hepatic veins, inferior vena cava. And when it does that, it can even cause rupture of the blood vessel for you to bleed. Arterial portal shunt. So as I said, it can create a hole in an artery and then a portal vein, like a hepatic artery and portal vein, and there will be a shunt from the artery to the vein. It shouldn't be so. Tumor thrombus. So since it has a propensity for invasion and bleeding, there could be blood clot. Blood clot. Thrombus is a blood clot in a blood vessel. So it can also form a tumor in the blood vessel, blocking the blood flow in the blood vessel, which can cause necrosis. Necrosis means that part, the cells over there are dying. It could be from some toxins generated, produced by some bacteria, and they are causing the cell death. Then infarction means that blood is not moving to the site. So that site is lacking oxygen, and that will cause what? Infarction. HCC can also cause that because it can form something like clot in a blood vessel and block the blood vessel, or tumor in the blood vessel and block it. And distal to the blockage will not have oxygen or blood supply, and it will die. That's infarction. Necrosis is also tissue death. Just that one is mostly from inflammations, infections, and cold. You understand? Yes. So the inflammation generated by the HCC can cause necrosis. Hemorrhage. Hemorrhage is bleeding tendencies, which I've talked about. It can create some holes in a blood vessel. Shunt, it can create shunt, and so bleeding is likely. Infection. Once you have liver cancer, you know that your immune system is low. The immune system is low, definitely. Yes, the immune system will be brought down, and any little infection, you can grab it like that. Yes. Now, on ultrasound, they are seen as small, typically hypoechoic lesion. You see, most cancers are hypoechoic. You should take note of that. Most cancers are what? Hypoechoic. And then larger lesions with mixed echogenicity. So they can also be large, not small, sometimes small, but many, sometimes to large, and mixed echogenicities. Hypo, anechoic, hyperechoic can be mixed. Densely echogenic mass. Diffuse lesions, meaning they are distributed haphazardly like that, precasing like that. Contour may be regular or vaguely irregular. So the masses, when they are huge, they may have irregular walls and can even change the contour of the liver itself. Liver becomes abnormally enlarged. That's it. Ultrasound variability similar to metastasis. Metastasis is hepatic metastasis is when the liver is having a secondary cancer. The spread is from somewhere else. So it looks like the HCC. They are all cancers. Hypervascular. Hypervascular means that what will help you to know that indeed I have confirmed that this is cancer is that put your Doppler on it. And the lesions will show increased blood flow. Because cancers, because of increased blood flow in them, that's why they can proliferate and grow so fast and become big, metastasize. So have you seen someone's liver? Have you seen these things in the liver? The moment you see this variable echogenicity, white here, anechoic here, hypoechoic here, mixed, and it is zigzag. The lesion is not well defined. This lesion is not well defined. You can see how it's appearing. You can see how it's appearing basa like that. So that is it. And you can see there's hyper inside, anechoic here, hypoechoic, hyper, like that, mixed. Over here, you see a nodule here, nodule here, nodule here, hyper nodule here, one huge nodule here. Like, once you see this, nobody should tell you this is likely to be HCC. HCC. And the liver is abnormally enlarged. So you see this too. You see a huge lesion here, and the liver is there. This is likely to be the gallbladder over here. A huge lesion over here. Yes, you have to put your Doppler on it. Yeah, and this huge lesion, even though it is well bordered, but you can see that inside has variable echogenicities. This one looks like lymphoma, and which looks like lymph nodes, lymph nodes in there. However, these are diffuse. They are diffused. That's what we call diffuse. They are diffused and distributed in there like that. Those are our cancer tumors. Fibromelar HCC is just I wouldn't waste time here, but fibromelar HCC is a type of cancer that affects young patients and adolescents. It's actually not that common, you understand? And it's not as deadly as the HCC. You understand? So when a young person gets the HCC, mostly the histopathologist can confirm that this is the fibromelar HCC. So that one, you will see a central scar. A central scar is mostly one mass, one tumor seen in the liver with no liver disease. It just came up like that with no liver disease, and it can be treated. Yes, you see central scar, which is pathognomonic. All right, now liver metastasis is the spread, you understand? So they are cancerous tumors that have spread or metastasized to the liver from another part of the body. I have explained this a few minutes ago. These tumors can appear shortly after the original tumor develops, or even months or years later. You understand? So the head of the pancreas is the most common site that cancer can spread, either from the pancreas to the liver or from the liver to the pancreas. That's the head of the pancreas and the liver. They are very common sites that liver can spread from this to that, this to that. You understand? So let's say the pancreas was having the cancer of the head in 2022. It can be there till, let's say, 2025 before it spreads to the liver. Yes, sometimes too, within 1 year, it is spreading, depending on your system. So it's normally referred to as secondary liver cancer. Secondary liver what? Cancer. Because I've talked about it, that when a cancer is moving from one part of the body to the other, then it is what? Metastasis, or what? Secondary cancers. Cancers from the stomach. So which organs that when it's afflicted with cancer, it can move fast to the liver? These are the organs. So the regular students, take note of these organs: stomach, pancreas, colon, gallbladder, kidneys, and other several organs can spread to the liver to cause liver metastasis. But I said that the pancreatic head is the most common site. Yes, to move cancer from there to the liver, and from the liver to the pancreas, the pancreatic head. The stomach is also one of the commonest sites. So liver metastasis can also spread and affect adjacent organs. When there is cancer of the liver, which organs are very close that you think contiguously it can spread to? Who can mention some? Which organs are very close? I know that liver cancer can even spread to the brain, but the thing is that contiguous spread is when the organs are closer. Hematogenous spread and lymphatic spread is when the organs are far. So contiguously, which organ is closer to the liver that cancer can spread from that organ to the liver, or from the liver to that organ? Who can mention some of the organs?
Say kidney.
So which kidney? The specific? The right kidney. Okay, what again? Okay.
Gallbladder.
The gallbladder.
Say the stomach.
The stomach. Okay. All right. So yes, that's true. That's true. So that is it. That's why we are saying they are adjacent organs. Adjacent meaning they are close. Okay. So on ultrasound, you see hypoechoic halo due to compressed and fat-spread liver. I'll show you what we call hypoechoic halo. Yes, it's a sign for metastatic diseases. Almost all metastatic diseases, you see hypoechoic halo around them. Not all of them do, but most. Cystic
The heart of the heart.
The heart. No, heart is not close to the liver. Mostly heart doesn't get cancers. Yes. Heart is mostly safe from cancers. It's not like it can't get, but it's not a candidate for cancer most of the time. So cystic, calcified, infiltrative, and echogenic appearances. So metastasis can be cystic. It can have a calcified wall. It can, and it spread. Infiltrative means spreading. Yes. Multiple masses can be seen, because metastasis is never one lesion. It's mostly multiple. Irregular tumor border, plus or minus enlarged liver. Because since it's cancer, definitely it will be irregular. It will have irregular border. Some cancers may have regular borders. Yes, that can trick you. You understand? The liver may be enlarged or not. So in metastatic diseases, it's not all the time that the liver may be enlarged. Yes, but it's enlarged in most of the times. Have you seen the metastasis? Have you seen the metastasis? Metastasis spread too much, like it spread because it is a spreading cancer. When it gets to the organ, like the liver, is spread quickly. But for the HCC, it's a primary cancer, so it can be just 1 or 2 lesions in the liver. But metastasis spread like that. Since anytime we hear of metastasis, it is spreading. That's the term, spreading. So once one tumor forms in the liver, within 3 months, they are about 4. 6 months, they are about 7. 10 months, 1 year, 2 years, spreading like that, and subsequently fill the liver. So they are spread like that, destroyed the liver cells. So have you seen someone's liver? Have you seen? What is okay? What is this structure here? Who can tell me? This structure. Okay, you.
Gallbladder.
Gallbladder, good. Gallbladder, good. Gallbladder. This depend. We are not the sonographers who took this scan. This can be the inferior vena cava, though. But don't forget that the portal vein can also be enlarged like this in cancers like this one. So for you to know it is inferior vena cava, you measure the size. And one other thing is also that in cancers, in liver diseases like this, portal vein can be enlarged as the inferior vena cava, portal hypertension. So that you can miss that. So it's better you use respiration. For inferior vena cava, it responds to breathing in and out. Yes. Once you breathe in, inferior vena cava will move with the breathing. And when you breathe out, the size will also move with the breathing out. That's how it is. You will see that the size is opening, closing with breathing in and out. But portal vein doesn't do that. There's a kidney cyst. Yes, kidney cyst in someone with liver metastasis. That means that it is metastasis. It's likely to get to the kidney. Do you understand? Then the last part is the primary hepatic lymphoma. Lymphomas are cancers that originate in the lymphatic system. The lymphatic system operates throughout the body as the backbone of the immune system. We all know that the lymphatic system is the immune, is actually the main thing when it comes to the immune system. You understand? So primary hepatic lymphoma is defined as what? Is defined as lymphoma either confined to the liver or having major liver involvement. Primary meaning it started from the liver and it is confined to the liver, or the liver is the most affected. Do you understand? The exact cause of primary hepatic lymphoma is unknown, although some viruses like the hepatitis B virus, hepatitis C, and Epstein-Barr virus have been implicated in addition to some drugs. So these 3 viruses are known to be the main causes of lymphomas, lymph nodes enlargement in the liver, low detection rate in the liver, increased peripheral vascularity on color Doppler interrogation. So if you put your Doppler on the lesion, the inside may not show flow, but the periphery, the wall and the borders of the lesion will show flow. Variable echogenicity, it can be hypo, hyper, or anechoic. Variable distributions, they are diffuse. They are diffuse, like many of them. But sometimes you can see it as one. But remember, for lymphomas, they are always many, like always. Immunocompromised patients are at risk. Those people having HIV/AIDS, their system is immunocompromised. The immune system is down, so they can develop the lymphomas. Then people undergoing transplant, organ transplantations. Yes, those people too stand a chance of having it, because organ transplantation, we give you some drugs that will bring down the immune system so that your body will not reject the new organ. So that can also cause the lymphomas to form. Then cyclosporin, there's also a drug that has the potential of bringing down the immune system. So you see lymphomas, that's one lymphoma, one here, one here, one here. This one, it appears like more cystic. This one here, one here, one here, one here. You see there are multiples. You understand? On Doppler interrogation, you see a lot of lymphomas are here. On the Doppler, you see that the lymphoma itself are not showing flow, but the surrounding tissues. You understand? Yes, the lymphoma itself are there. The color box is on it, but if you check very well, the lymphoma themselves are not showing flow like that. Yes. And that ends this presentation. Let me take your questions. If you have, okay, somebody is asking, what are the symptoms for it? Please, which one is that? Is it the fatty liver disease?
So you've already answered that question.
Oh, okay, all right. What of taking too many fermented foods and others? Oh, fermented foods, we know that the end products, it's mostly alcohol. You understand? So the body has a level of alcohol that when you give to the body, it wouldn't cause cirrhosis. Cirrhosis will only happen when you take the alcohol too much. And those fermented foods, they do not have that level of alcohol that can destroy the liver. Do you understand? So fermented foods are less likely to cause liver damage. They are less likely. Yes. Yes. Similar to metastasis, the lymphomas is similar to metastasis. Yes. They are all cancers. You understand? That is why anytime you write any report regarding cancer, you have to recommend for what? Histopathological assessment. That is biopsy to confirm. Do you understand? All right. Please, any question? I think I borrowed your about 15 minutes or so. Yeah. Any question? So I would